Real life? All right. Good evening, and thank you for joining us for this, what we think is an exciting session. Next hour or so planned for you. And you've gone through the instructions of making money here, and then if you still want to, you can go across the street at the casino and try your luck. Okay? But I am Milind Desai from the Cleveland Clinic, and with me is Dr. Desai Owens from University of Pennsylvania. And the next hour or so, we are going to talk about what we seem to think we know about hypertrophic cardiomyopathy, all the new stuff that is happening. How do we take care of patients in the cardiac myosin inhibitor era, elevating outcomes with cardiac myosin inhibitor? So again, I would like to thank PeerView for providing this session and Bristol Myers Squibb for providing the educational grant for this symposium. The content was created entirely by PeerView and Dr. Owens and myself. Please complete the pre-event survey and look out for some polling questions. And don't forget to send some questions for the Q&A. I was informed today there's no other session following us, so if we go a few minutes over, it is okay. Dr. Owens may not like that, but just letting you know. And you can use your personal device to scan the QR code on the following slides to respond to poll and ask the questions. And for the virtual learners, respond to polls on your screen. So this is the QR code for the $50 gift card. Anybody is interested? This is where the action is. And this is, if you want more educational material, you can go to the PeerView site, and there's the QR code. So what do we plan to achieve? We need to recognize that early recognition and differentiating HCM from other things is crucial for optimizing outcomes. We will talk about guideline-based management of obstructive HCM, which now includes cardiac myosin inhibitors. We'll talk about data on CMIs, and basically we will approach real-world data as well as the concepts of shared decision-making. Again, I'm Milind Desai. Dr. Owens has told me to not make any mother-in-law jokes today, so
None.
I will not do that.
Not at all. Casino is free game, but no mother-in-law jokes.
Yes, okay. I always do that. So, obstructive versus non-obstructive HCM anatomy. How do we define HCM? It is more than 15 millimeters or more than 13 millimeters in family history individuals in association with the positive genetic test. This is something that has been in the folklore since 1973 as we have read the papers, but I think right in front of our eyes, the definition may be evolving. So be on the lookout, not just for new therapies, but for these kind of things, new definitions. The full spectrum could be normal, without obstruction, to all the way obstructive, apical, mid-cavitary, etc. And over the course of one's life, progression may occur from one phenotype to the other. This is an equal opportunity offender, okay? And it is certainly clinically underdiagnosed. The prevalence is about 1 in 500 to 1 in 200. Median age is 46. If this is a genetically inherited disease, and if the median age is 46, then at the very least, we need to do something to move the needle leftward. Underdiagnosis is 2 cases missed for every 1 diagnosed, and 700,000 folks in USA. If you take India and China, the other day I counted with 3 billion people there. That's a lot of people, 6 million people. So think about all these things. And there are disparities in terms of diagnosis as well as care. When should we suspect HCM? exertional dyspnea, dizziness, syncope, chest discomfort, palpitations, et cetera, et cetera, et cetera, right? All of this sounds like somebody with heart failure, somebody with angina, somebody with what have you. But if this is in the context of autosomal dominant inheritance, deaths, unexpected sudden cardiac deaths, heart failure, stroke, and the dynamic LVOT murmur in the setting of an abnormal ECG, all these things lead us to the promised land of a diagnosis. We've recently published at ESC on long-term outcomes in asymptomatic individuals. A lot of us are going to be dealing with these patients, right? In 3,000 plus patients. Look at the median age. Mean age is 61 years. Over 10-year follow-up, about a quarter of these folks became symptomatic, and those who were obstructive had worse longer-term outcomes compared to non-obstructive. This is data from yesterday. Again, 1,299 patients who underwent stress echocardiography at the Cleveland Clinic, all asymptomatic. What we showed is non-obstructive HCM does better, but folks with obstructive HCM who do not undergo myectomy have worse outcomes. Patients who do not have appropriate exercise capacity on treadmill have worse outcomes. The other thing is about 22%, so 1 in 5 patients had latent LVOT obstruction. So just waving your hands on resting echo when they don't have a gradient is not enough. You gotta work on it to elicit the gradient. That brings us to what is appropriate imaging, and the guidelines prescribe the following. Echo is the mainstay, first line. Okay? It helps characterize disease, LV outflow tract gradient, mitral valve, screening, as well as follow-up. Cardiac MRI does provide adjunctive value, including myocardial fibrosis. TEE is generally reserved for undiagnosed cases or for procedural planning. And nowadays, there's emerging role for scintigraphy because about 10% of HCM folks may have amyloid. So here's an answer, a question, a riddle. This late on Saturday night, 48-year-old patient presents with occasional fatigue and exercise intolerance. Family history of sudden cardiac death, you suspect HCM. What test would you order after the initial ECG? Stress test, genetic testing, TEE, or TTE? Please scan to answer. Oh, sorry. Okay. Can we move forward? All right. TTE. Yeah, I think that's appropriate under the circumstances, right? We need to understand phenotype and morphology and all that good stuff. So, this is again new data. Yesterday, at the HCMS, we talked a lot of things. You know, multimodality imaging. We are moving rapidly towards AI, helping us refine the diagnosis and potentially index it based on age, sex, body surface area. You know, there's new data that is going to come out in the next year about incremental value of cardiac MRI. You know, this will result in refining of the guidelines. We talked about the practical challenges of imaging of patients on CMIs and how to navigate those. And then, you know, about 40% patients with HCM are genotype positive. What the heck do we do with the other 60%? Right? So there's emergence in understanding that there may be polygenic risk scores that may influence who develops HCM, et cetera. So this field is rapidly evolving. What we are talking about today may become obsolete next year. AI, you know, we are using AI in earnest to make the diagnosis of HCM on routine ECGs. And in one of the studies we did at the Cleveland Clinic, at main campus Cleveland Clinic, in the first 6 months, we found 50 new patients that were lurking around. So if that's the state of affairs in downtown Cleveland, imagine in rural practices, et cetera. So AI is helping us a lot, or will help us a lot. AI, using point-of-care ultrasonography, helps detect almost 60% HCM cases 2 years earlier. The world is moving towards earlier diagnosis so that we can do earlier treatment, right? This is 290,000 standard echoes done at Yale University and Mount Sinai. So the world is rapidly moving towards earlier diagnosis using intelligent machines. Let's introduce Jordan, not Michael, just Jordan, a patient aged 62 years, presenting for cardiology follow-up, intermittent palpitations, mild chest pressure, worsening dyspnea and exertion, right? This could be 200 million adults in the world with this. ECG performed, medical history has paroxysmal AFib, hypertension, dyslipidemia, all the other usual things. He is on metoprolol, DOAC, and atorvastatin, okay? This is his ECG. You don't need AI. If you need AI for this, God save us, okay? This person has LVH with strain pattern. So as we suggested, let's proceed to TTE, okay? It is important to know not all thick walls is HCM and not all HCM is thick walls. Differential diagnosis widens with age. The less hair you have on your head, the wider the differential. It could be hypertension, aortic stenosis, HCM, athlete's heart, amyloid, Fabry's. Younger patients have Pompe's and Danon's. So all these phenocopies you have to ascertain. The last thing you want to do is give mavacamten to an amyloid patient and vice versa. This is Jordan's ECG. At rest, there's basal septal hypertrophy. With Valsalva, Houston, we have a problem. Sam with outflow tract flow turbulence and posteriorly directed jet of MR. 2 centimeter basal septal thickness, moderate severe SAM, posteriorly directed MR, 62% EF. Valsalva gradient is 75 millimeters of mercury. Hallelujah, Jordan is diagnosed with obstructive HCM. That brings Dr. Owens to the clinic. It takes a lot of effort to bring Dr. Owens to the clinic, but Jordan, she'll be there for him.
I'm here. So we're going to jump into long-term evidence, real-world data, and updated guidelines, looking at CMIs. So prior to 2023, we were using therapies based on very limited data. Limited evidence in terms of lack of randomized controlled trials, often observational, single-center, expert opinion data. And that started with the beta blockers in the 1960s, moved to the calcium blockers into the 1970s, and eventually the addition of disopyramide. None of these medicines were developed to target the underlying pathophysiology of what we see in HCM. They were drugs that were developed for something else, but were repurposed because of their effects to see if they could improve diastole, to reduce contractility, and see if they could really improve symptoms in obstructive HCM. It's really not until the CMIs were developed that we had the first targeted therapy for patients with HCM, and we saw that the first CMI, mavacamten, was approved in 2022 for the use in obstructive symptomatic HCM, incorporated into the ESC guidelines in 2023, and into the American guidelines in 2024. These are small molecules that are taken by mouth. They are importantly reversible, and they target the cardiac myosin and not skeletal muscle. And there are two drugs that are furthest along in their development. The first in class, as I mentioned, mavacamten, and the next in class, aficamten. Again, these are supported by prospective randomized controlled trials, which is a new era for us in hypertrophic cardiomyopathy. They act by modulating contractility at the level of the sarcomere, so the contractile unit of the heart, and they take a heart that's hyperdynamic at the level of the sarcomere, working too hard and poorly energy efficient, to one that is contracting more normally and relaxing more normally. Importantly, if you get too much of a drug effect with this mechanism of action, there's a risk of becoming hypocontractile. And fortunately, because they're reversible, if that occurs, you simply have to pull back on the dose, temporarily hold in the case of mavacamten, and down titrate in the case of aficamten to modulate that effect. So similarly to how cardiologists use positive inotropic agents to modulate contractility up, this is the use of a negative inotropic agent to modulate contractility down. This opens the paradigm shift that hypercontractile can be bad. High EF can be just as bad as a low EF, and really what you're targeting is that sweet spot in the middle. So what have we learned about cardiac myosin inhibitors? This is data presented on obstructive HCM. We had the first pivotal phase 3 trial, the Explorer trial, that was looking at mavacamten versus placebo. Now that placebo group was on background standard of care medications, which are a mix of beta blockers, calcium blockers. Disopyramide patients were excluded from that first pivotal trial. Those patients were then rolled into the MAVA-LTE open label extension trial, and you can see that that trial is ongoing. The next phase 3 trial for mavacamten was the VALOR trial, and we'll present long-term data from both MAVA-LTE and VALOR today. The VALOR patients were sicker. All of them were under active consideration for invasive septal reduction therapy. So they were being considered and they were candidates for either septal myectomy or alcohol ablation. These patients were also on much more background medical therapy, combination of beta blocker and calcium blocker, beta blocker, calcium blocker alone, and a significant proportion, around 20%, also on disopyramide. So really maximally medically treated, but remain symptomatic and obstructed. The next series of trials that I have listed here are for aficamten, the next in class cardiac myosin inhibitor, starting with the pivotal Sequoia trial, phase 3. This was aficamten versus placebo, where the placebo group was on background standard of care therapy, beta blockers, calcium blockers, some on disopyramide. And finally, the newest trial for aficamten, which is the MAPLE HCM trial. This read out very recently in Madrid at the ESC conference, and for the first time, we saw aficamten CMI versus first-line standard of care metoprolol, both as monotherapy. So we'll get to those results. Patients from the aficamten program have rolled into FOREST HCM. That is the open-label long-term extension. So let's start with the MAVA-LTE data. This is, again, patients from Explorer, obstructive HCM rolled into long-term extension. What's important to note here is we now have data out to 180 weeks of treatment, so 3+ years on mavacamten. And what we've seen is sustained and impressive reductions in LVOT gradients, both resting and Valsalva, with Valsalva gradient reduction in the aggregate group reaching more than 50 millimeters of mercury. We've seen sustained reductions in NT-proBNP and sustained improvements in quality of life scores. It's sustained improvement in NYHA class with nearly 80% improving by greater than or equal to 1 functional class. Now, we've also seen, as expected by mechanism of action, a decrease in LVEF, in that contractility that's being modulated. But in aggregate, we have patients with an EF still in the normal range of 64%. We're taking people that are hyperdynamic and putting them into the normal range. This is important because it tells us that people can take this drug potentially lifelong with durable benefit and also durable safety, which is important. So what's new in terms of mavacamten data and obstructive HCM? We have that there were Explorer results from MAVA-LTE that I will be presenting, and this will be the first time that we're looking at effects of the drug in long-term fashion based on duration of HCM diagnosis. So this will look at patients who were diagnosed greater than 10 years ago, 5 to 10 years ago, 0 to 2.5 years ago. Really to get at the question is, does it matter when you start this drug? Will you be able to see the same efficacy and safety? And we'll present that data on Monday. So looking at favorable cardiac remodeling, beyond the hemodynamic effects of gradient reduction, which is important for symptoms, what are we seeing with this class of medication in terms of long-term cardiac remodeling and how this might relate long-term to a change in the natural history of disease, which is ultimately what we're looking for with a medication. Can this drug change the course, the natural course of disease in this patient, and ultimately allow them to avoid the complications that we know can occur with HCM, which are AFib, heart failure, stroke, ventricular arrhythmia. So what do we know about remodeling? And here's data from the MRI sub-study. So it's a relatively small number of patients, but still a good number who got MRIs. And this is based from both the US and the Asian studies of mavacamten. And you can see what we've seen is pretty remarkable changes in indexes that represent adverse remodeling in this disease. So improvement in left ventricular mass index, improvement in left atrial volume index, improvement in maximal wall thickness. Now again, that's the hallmark of this disease, is pathologic hypertrophy. So if we are seeing regression of that hypertrophy in a compensated heart, a heart that has a low NT-proBNP, a patient who's asymptomatic, that's favorable remodeling. And again, the LVEF in this group by MRI was down by about 4%. This is data from VALOR. Again, VALOR were those sicker patients who were on the cusp of getting an invasive therapy like myectomy or alcohol ablation. And we now have data out to 128 weeks on these patients. And you can see here that only 7 underwent SRT. That's pretty remarkable. When you take a patient who is class 3, over 90% of these patients were class 3 at baseline. They were actively considered for invasive therapy, and they were able to not need that invasive therapy out to at least 128 weeks. And you can see on the right-sided panel, improvement in KCCQ score, quality of life, improvement in NT-proBNP, and troponin. So what else do we know about structural changes, remodeling from VALOR? We saw very similar changes to what we saw in Explorer. So even in that sicker group of patients, we're seeing improved left atrial volume index. Once you relieve that obstruction, the left atrium starts to shrink down. It's under less pressure. We saw that longitudinal strain improved. So that's an interesting finding. Even though you're modulating contractility by our somewhat blunt instrument of an LVEF, even though my friend is a cardiac imager, I can poke a little fun at it, it's still a pretty blunt